Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes. Today, we're highlighting how metabolic health can transform employee wellness. By prioritizing real health, our clinics are helping employees lose weight, reverse chronic disease, and even come off medications they thought they'd need for life, all while saving employers thousands in healthcare costs. If you're an employer looking for a proven way to improve employee well-being and reduce medical expenses, this episode is for you.
Welcome to the Low Carb MD Podcast. This is going to be really great. We're going to be talking, we have a returning guest, and we're going to be talking about a lot of interesting things. Maybe a little bit about metabolic health, maybe a little bit about dietary changes throughout the lifespan, maybe a little bit about data crunching. Maybe it'll be funny and light and social. Maybe it'll be serious. Who knows? We may make America healthy. We may come up with a blueprint to make America healthy right here in this podcast. Guys, we are back here with Dr. Laura Buchanan, and I'll do a brief introduction. I've had the pleasure of working years with her, and I probably don't have to introduce her, but she's literally the smartest person I know, and full stop, smartest, brightest person I know. She is board certified in family medicine, board certified in obesity medicine, a metabolic health practitioner. She is also board certified in by the North American Menopause Society. Gosh, I don't know if there's a board certification you don't have yet. You got to work on your lipidology, Dr. Laura. She's been working in our practice toward health for the past several years, and it's been my absolute honor to work with her and to get to know her. And so thanks for coming on, Dr. Laura.
Thank you so much, Tro, and thank you for that very, very kind and generous introduction.
What did I miss? Tennis champion. I forgot the tennis champion. State tennis champion, mother, slayer of dragons. I forgot all those things. It's been an absolute pleasure. And I think, let's just see where the conversation goes. I think some of the conversation today will go towards the paper, the 1-year paper, which, gosh, took us a bit to get published, but finally got published, and we'll put it in the show notes, talking about the 12 months weight loss and deprescription data. Let's see where it goes. Well, how are you doing today? Let's start there.
I'm doing very good. Happy to be talking with you on a Saturday morning.
Oh, gosh. Yeah, absolutely. Well, so I'm curious, okay? Let's go back a little bit, right? And this is just my own curiosity, okay? Because I've gotten to meet some of your family, your mom, brother, son, husband, who are all amazing, by the way.
I am blessed, yeah.
I'm curious, because you're the only there's one other person in your family who's in the medical field, right? But tell me, did I get it wrong?
None of my immediate siblings, but cousins. There are other cousins in the medical profession.
So when you were growing up and you were like, I'm going to be a doctor, when was that moment?
So really, it was during college. I thought something medical, but I really didn't know nursing. I shadowed physical therapists as well, and I thought maybe that was the route I wanted to go. But
why physical therapy?
I love sports. I had a couple of injuries myself growing up, broken ankle, had some recurrent ankle sprains, and I did physical therapy, and so I was always appreciative of the help and them getting me back to what I loved. And so I thought, well, maybe that would be fun. But then when I shadowed the physical therapist, I did enjoy it, but it didn't give me as much of the sense of fulfillment that I was looking for. And my brother, and I mentioned nursing to my brother and helping take care of people. And he said, no, if you want to take care of people, become a doctor. And so I was like, you know what? I think you're right. And I pursued that.
And when was that? That was like middle of college. And where did
Yeah.
you go to college? Remind me.
University of South Florida.
Okay, so you're at University of South Florida, and your brother's like, you should go to med school. And you're like, you know what? I'm doing this.
Yeah.
But you had some sort of calling to help people. I mean, you're thinking nursing, you're thinking, physical therapy.
100%. Yeah. Even during my anatomy course in high school, I loved anatomy, and that was probably one of the initial things that got me down the medical pathway, and then just wanting to help people. But that's very generic, wanting to help people. You can do that through many different paths. So
Well, yeah, I mean, it sounds like you were exploring that. I mean, something about the human body. You're an athlete. And you're like, I just want to do good. I want to help. And
yeah. And I saw it was a huge, sorry for interrupting, but a huge thing during high school as well, where I saw the impact that lifestyle changes was having on people in my own life. So I was seeing my grandparents, some of them were aging extremely, what I would say, well, and whereas others were struggling with some chronic medical conditions. And it was really through their lifestyle that it was very obvious what was driving that.
so, like, you're also now putting together sort of the chronic disease epidemic. You're very active. You're keeping healthy. You're trying to, you're caring. You're trying to, I guess, do good, be good. Clearly, you're very bright. And then your brother's like, no, you're going to medicine.
Yeah, that was a large part of it, I think.
Was that your brother Ben?
That was Ben. Yeah.
That was Ben.
Yeah, and he actually this was during college. Yeah, he helped me. He set up basically a trip for me to go to Peru. We have family in Peru, and actually go work at a rural hospital. And that was a really eye-opening experience that was just kind of, I think, solidified that this was the right path for me.
Can you tell me about that?
Yeah, so we were in a very small hospital, kind of separated from the larger cities. It was entirely fenced in and gated with security guards because the area was not a safe part of town. And we were working in the emergency room overnight. And it was basically, there was no privacy. There was no, it was just people walking in who needed help. And you had, 10 people all in a small room. I was suturing up someone's forehead while someone else was coming in with a laceration. Their arm had been cut really severely. And then someone else was doing something in the corner of the room, just relieving themselves. I mean, and it was chaos, semi-organized. But the doctors were amazing, and the patients were super appreciative. And the material and the limited supplies that they did amazing work with. One of the things that I was really surprised about, this was the next day at the hospital, but there was someone who had a broken leg, and they wanted to elevate the leg. So they had 2-liter Coke bottles tied with strings and had tied that to the person's foot and basically using it as a levy system to help elevate the leg.
Oh my God, that is kind of, I mean, whatever works, I guess, right?
Yeah.
But wow, I mean, what a powerful image just to think of, like, the chronic disease epidemic. You're in a hospital, suturing people, helping people, and you're using like, gosh.
Yeah.
So then you go to med school, then I guess is that where you met Matt, or you guys met in residency?
We met in med school. It was actually a week before med school started. We had this little issue where we both wanted to go to the gym before classes started, and the parking permit was off because the undergrad semester was different than the med school semester. So we were both in the parking permit office questioning how we could get to the gym before classes without having parking passes.
My God, this is like a Make America Healthy couple in the making right here. Who could get to the gym earlier? who could do better on their board exams,
Yeah.
That's kind of, what I'm going to tell my daughter that. I'm going to say, if you want to meet it, because I met Dr. Matt Calkins, who's a great metabolic doc also. And I'm going to say, if you want to meet somebody good, Aline, make sure to go early in the morning to the gym. Okay, so you go through residency, you go through, clearly we've talked about how you saw our modern system isn't good enough. And maybe I'd just love to hear you talk about that a little bit. I think the average listener, they have an idea that the system doesn't work, our medical system. And I'd love to just hear it from your point of view, maybe all the things you think really don't work, before we end up talking about the 43 pounds we helped, employer, the patients lose in an employer setting.
Yeah.
Before we go to sort of the solution we've been working on to these problems we see, can you just describe all the problems in medicine? And I know it's going to be a long list, but let's go through some of them.
So, part of it starts in medical school. You don't have adequate training on nutrition. And the nutrition training you do have, we had a 2-week intensive, which I think honestly is better than many medical schools. But even during that 2-week intensive, the nutrition that we had was, a lot of it was old dogma. Saturated fat's bad. Then it was some classic nutrient deficiencies you have to know about. And there was no practical advice truly about how to educate people on lifestyle changes. Tell them to eat less and move more. Well, that does not help almost anybody. So I think that's one of the huge issues. So lack of education. And then moving on to during residency, the lack of education continues. In the clinic space, you have a little bit more time with patients in clinic as a resident. It does start to decrease as you progress through your residency. And so just an example, for many of my patient visits, they're 15-minute follow-ups. And I did try to practice metabolic health, helping people change their diet, like truly change their lifestyle in residency. And so most of the time I was running behind because I can't really help someone with their lifestyle changes adequately in 10 minutes. And outside of residency, I know there are other docs, and I've talked to patients, they'll wait 30 minutes to see their doctor, and then they'll have a 7-minute appointment or a 10-minute visit. And in that 10-minute visit, you have just enough time to review the current medications you're on, see if there's been any major side effects, and then potentially, if your blood pressure is high when you've been waiting for that 30 or 45 minutes, where your A1C is still higher than goal, then I'm going to add another medication on, because I can do that in 1 minute. That's easy. So that is kind of the standard model, really, in medicine. It is oftentimes a medication focused to treat diseases rather than prevent or reverse disease.
I think you hit the nail on the head for the doctor, right? The doctor is pressured by these forces to see people more quickly, and then the surrounding support, the front desk, the medical assistants, right? They are, sort of programmed by the dietary guidelines, the food pyramid, the institutions we're in, sort of, promoting that. The dietitians at these institutions are promoting that. So even if you were, woken up to battling chronic disease, and you're in one of these systems that you really are forced to be as a doctor, it's tough to envision a way out, right? It's tough to actually imagine, hey, wait a second, we can make something completely different. We can make something better. We can do better. But I want to cover some other stuff, because I think, you probably were exposed to it, but, the insurance system also, I think, is one that's tough, and people need to understand this. And maybe I'll give a little tidbit and hear what you think about the insurance system. The insurance system, so not everybody may not know this, but they make money actually off of people being sicker and spending more money. So the insurance companies that are out there, they are allowed, the admins they're sort of like a casino, right? They can only make 15% of the total amount coming in. So when these expensive drugs come out, or when new procedures come out and are very expensive, they're actually excited. They don't want to deal with it all at once. They want to be able to pay for it, right? Because then the pool of which they could share for their salaries and their bonuses can go up. So I'm curious to hear your thoughts on sort of insurance companies and the whole insurance system, and how it affects the person in front of them, how it affects the patient going in who's sick, how it affects the docs out there. Do you have any thoughts on all of that?
I mean, it's definitely, the incentives are all wrong. And so if you're incentivized to keep people sick, basically, because you earn more money when people are more sick, then right there, that's all you need to hear. It's a broken system. But I think there's, and I don't know as much about the PBMs, but there are other incentives in medicine, and this might relate partially with insurance. Whereas some examples, there are doctors will get bonuses or extra incentives in some instances for prescribing medications if their patients are meeting the quote standard of care. So in residency, there's times where I would have some pharmacist or nurse whose job was basically to chart review, and they'd say, hey, this patient is not currently taking a statin medication. And so if I had more of my patients on statins, now in residency, I'm not going to get any bonuses, but out in private practice, you can actually get money or reimbursements for meeting certain quotas, basically. And this can be things like certain medications for certain medical conditions, or it could be vaccines for children, as an example. If pediatricians get large bonuses if X percentage of their patient panel children are vaccinated fully. And that also ties into other healthcare maintenance things like colonoscopies or other screening tests as well, which is not all bad, but you can see the conflicts there. And then the doctors losing, I think, even if it's subconsciously, less likely to have a good informed consent and discussion with the patient if they have an incentive to convince that person to take something because they make more money because of it.
Yeah, I think if you look at it, the doctor is incentivized by insurance to see patients quicker, right? Because they're going to get paid a certain amount, so they're going to be incentivized to see patients quicker. I think that the insurance companies, are incentivized by being obstructive, right? By, not really, what are the, if they deny a claim for medication or a procedure, right, they get to make a little bit of money, right? And if they, or if they make it a little bit difficult, and slow down the rate of expensive medications, but in the end, as long as the top value goes up, the top dollar goes up in a managed way, not all of a sudden, they win out. And so I think it's a huge problem. And then what this leads to is, companies throughout the United States, that when they get a certain size, when they get above 100 or 200 or 300 employees, then they say, wait a second, we want to manage our own health. We want to try to, we want to be self-funded. Like, yes, we will have insurance, okay, but we'll take on the risk and we'll try to get our employees healthy. And I guess this is a way to sort of battle costs for these employers, right? And it's a way to actually invest in the welfare of the people in their company, right? These companies, whether it's a tech company, a reinsurer, a trucker, a fencing company, a manufacturing company, once they reach anywhere from around a couple hundred employees, it makes sense for them to say, you know what, insurance company, we'll still use you, but we're going to be on the hook for our people. and we want to self-fund. We want to pay for our medical claims. All we need you to do is, manage the medical benefits, right? So, and presents a unique opportunity, right? Now the employer gets incentivized to get healthy employees, right? To save money against this terrible medical system. And I think that's where we come in, right?
Yeah.
And the other thing that's happening that coincides with this self-funded movement and captive movement in the employer industry is the direct care movement. So on the corporate side, we see companies starting to actually care how healthy their employees are, how good they feel, how their mental health is, how their physical health is, how much chronic disease is there. They want a healthy and happy workforce because healthy and happy employees work harder, they lose less days due to sickness and disability, right? So that's one side of the coin. The other side of the coin, this beacon of light, is the direct care movement, which is aligning the patient and the doctor. In the direct care movement, patients pay us, and if we don't serve them, they can walk their dollars elsewhere. So we are incentivized to keep, as a direct care company, to keep people healthy and happy for as long as possible. We have to actually provide a good service. And then 3 years ago, a manufacturing company, or 4 years ago now, a manufacturing company came and said, maybe we can team up. So I think you've been here just about throughout most of that. So maybe you can talk about what it's been like to sort of see what direct care feels like, and then to see sort of this initial partnership. Now we have 5 or 6 corporate partnerships, but what was it like to see all that?
Yeah. So, I mean, coming from residency, I was very fortunate in that I came straight into practice working with you. So I did not have years of working in a practice where I had to see patients every 10 minutes. I was, again, very fortunate. So now my initial appointments are an hour and a half long. So I can really take time to get to know the person in front of me, see what their goals are, let them know about some of my goals and help them. And really, I think that is, it's such an optimal way to practice medicine. And so I love what I do, and the follow-up visits similarly are anywhere from 30 minutes to an hour long, and sometimes people don't need that whole time, especially as people are kind of later into their health journey. Oftentimes, most of the visit is just talking about life because they're crushing it on, they're off their medications, they have lost a bunch of weight, their diabetes has been reversed. So you're just checking in, seeing if they need any help, and then enjoying the company. And so, so the direct care has been wonderful. I could not imagine practicing a different way. From the employer and working with employees, I find that also really fulfilling. The employers themselves, it's really cool to see how much they care about their employees and the health of their employees. And then to also just get to work with people at basically throughout all levels of the company, from the C-suite to the manufacturing lines to the truck drivers who are driving across the country on a regular basis, to have to get to try to really help them with their metabolic health. And you can imagine the different advice you're giving to those different groups of people, because it just takes eating a different style if you're spending a lot of time driving across the country versus working in an office all day.
Yeah, I think, I think when we started working together, we didn't know. Like, I remember when I first sort of talked to this company came to me and said, they sat down and they said, the CEO, the HR director, they said, look, we know metabolic health is a problem. They were light years ahead of everybody else. Now everybody's talking about metabolic health. on a sort of nationwide scale, but they were talking about it um, before all of that. And this was about 5 years ago, actually. And they said, we want to do something. And I looked at the literature. I know you would have done the same thing. And I did an audit. I went and looked at every wellness program in an employee wellness setting, right? And they all were utter failures, right? So I was so surprised, by their interest, because I'm like, hey guys, why are you interested in this? The data's been miserable. And they said, well, we need to do better. And then once we do better, their mission was clear. They're like, we need to scale this. So, when we started this pilot program, it was just 12 patients. And we really didn't know. We had an idea at the time because Virta had announced their 1 or 2 year data. So we had an idea that we could do better. And you're absolutely right. Like seeing that disparate amount of, all different types of employees, everybody from the manufacturing line all the way up to the executive suite, how to cater to them. Will it work? Will it work at every level? And I think I was surprised by the initial results. So what did you think about, when we published and I'll put it in the show notes, that initial results, when we started analyzing the data, what were your thoughts?
The 12-month data?
Yeah, no, let's start with the 6-month data. Let's go back. Yeah, we'll definitely talk about the Toward study and Frontiers. Yeah. But, when we first peeked at the data.
It's amazing. It was fantastic. You look at the blood pressure improvements were huge. If I remember correctly, it was 17 drops in systolic, and that was while stopping numerous medications. So you had a 17-point improvement in blood pressure while stopping multiple blood pressure medications. And similarly, drop in A1C while stopping numerous diabetes medications and insulin.
What I was surprised was when we ran the numbers in the 10-year AHA, ACC index, and there was a 44% relative risk, and a 4%, absolute risk reduction, which, to me, when I went back to the company and said, hey, look, this is the results we're getting, it gave me hope that, hey, wait a second, we can do this on a larger scale. And then we did it on a larger scale. Our coaches, Amy Igus, Brian Wiley, Vic, Tia. We then enrolled several other cohorts. So what were your thoughts before we peeked again at the data? Like, what did you think? What were your concerns? What were your thoughts? Did you think that we could scale an intervention like this?
Yeah, no, I was very optimistic because I was seeing the patients like you were on a regular basis, because we have at least monthly follow-up depending where they are in their journey with us. And most of the people I was seeing were having great results, and they were telling me how much better they were feeling. And I'll just throw it in here and maybe we'll talk more about it later. Although this isn't in the paper, it really is one of my favorite things about practicing this way, is getting to hear all the patient stories about different ways that their quality of life has improved so much.
So what do you mean by that? So, we'll talk about the paper results, but, I have some thoughts about quality of life. So I'm just curious, what do you mean by the quality of life? What are the things that stand out for you?
Yeah. So I had numerous people actually tell me the story about not having to ask for a seatbelt extender on a plane and how much that meant to them. And then I had people who were not able to go on roller coasters that could now go on roller coasters again. And they were able to walk around Disney with their family and not have to sit at the park bench and say, hey, go on, I'll catch up with you later. And another one was some people who they used to love to go to the local high school games, but then they no longer fit in the stadium seats. And so that was really hard for them. They didn't, they lost that fun event together. And then they were able to start doing that again. Someone else was able to start riding a bike again. And so these are things that you may not think about when you're looking at someone in front of you you're working with to try to improve their metabolic health. But then as they're telling you these stories, you realize how important and how much of an impact that has on them.
When I look at, just to echo what you're saying, like we really got to know these people, and to talk about the power of an intervention like this, that's beyond just diabetes, right? So VERT has shown that they can do a decent job with diabetes, but what we did was a little bit different. We said to these patients, we're going to be your urgent care, we're going to be a second opinion, we're going to be your preventative care, we're going to make sure everything, because a lot of these people didn't even have doctors, right? They didn't want to see a doctor. They were too ashamed to go to the doctor. Maybe they didn't fit into the waiting room, or maybe they didn't fit into it, the exam table, or maybe they just hadn't gotten convenient care. And what we found was, not only did they lose a ton of weight, and this isn't in the paper, and we'll probably look to quantify this later, but we diagnosed completely remotely a couple of cases of cancer. We identified issues that were very risky, elevated calcium scores in patients before they started our program. And so I don't think we can, there's all these other elements of actually providing good quality care. I mean, when they have an acute issue, whether it's, a question about a diabetes medication or a symptom that they're feeling, we were able to provide comprehensive care. And I think that this, actually prevents burnout for doctors, because we're now not having our scope so limited, right, into just diabetes or weight. We're also able to sort of look at the person holistically, look, at their medications. Hey, has your asthma improved? Maybe let's come off that Montelukast that has a, suicidality black box warning on it. Hey, when we expand our scope beyond diabetes and weight, we're able to address the reflux medications that maybe they don't need anymore because their reflux symptoms are gone. Or, maybe their mood has changed and they haven't seen the, psychiatric NP in a year, but they want to start to taper, very slowly some of their, SSRI medications. I think that's what surprised me, is the impact we had. I mean, there was a case of parathyroid cancer we diagnosed, colon cancer, just by doing good medicine. So, I almost, when we first started, my biggest question is will we really be able to have an impact on people who don't know what metabolic health is and don't know, who Dr. Laura is and Dr. Tro are? Will we have an impact on all comers, right? And quickly we saw that we had, with that pilot study, we knew we were having an impact. But then, what I was surprised by was all these other things that we're able to do, just by being present and doing good medicine. I don't know. What are your thoughts?
I 100% agree. And it's, there are times where I was like, oh man, we should work on writing a paper with some of these things, like just showing the impact that a direct care style model could potentially offer. But, that would be a difficult paper to write, and how do you design it, and, writing the patient stories. But I think it's still, I have thought about that, because it's a huge impact on people's lives.
Well, let's talk about this paper, because you were the first author, and you crunched all the data. So walk us through some of the things that you think are really important about the Toward Health paper.
Yeah, for sure. And I real quickly, just to set the scene, which most people probably are starting to know some of these numbers now, but in the US, 38% of adults have prediabetes or type 2 diabetes, and 42% have obesity, with certain populations having a 50% prevalence of obesity now. The cost for diabetes annually, just on direct care costs, not indirect costs, is over $400 billion. And for obesity, it's over $170 billion annually. And we know that depending on which marker you're looking at, 88% of the country has some component of metabolic syndrome. and only about 7% of the country has what may be considered optimal cardiometabolic health. And so we are in a desperate space right now to find a way to create a sustainable, cost-effective, we just talked about those huge costs, to reverse this metabolic health epidemic that we are in the midst of right now. And so with some of those numbers and stats in mind, I think what is, really exciting about our paper, and I'll kind of jump right into the weight loss and deprescription data, is in our 50 patients, there is a 15.5% of total body weight loss, which was just under 20 kilograms at 1 year. And 15.5% of total body weight loss is really good and actually beat step 1, which is the kind of famous semaglutide 2.4 milligrams or Wegovy trial, where at a little past 1 year, they had a 14.9% total body weight loss. So I think, and again, going back to the cost, we stopped 96 medications while helping people lose that significant amount of weight. And whereas if you add Wegovy for 1 year, depending on insurance, is going to cost you $13,000 per person.
That's a lot of money. I mean,
if we just want to do a little bit more math here. So if you took all of the people that qualify for the GLP-1 medications now in the United States, which is 142 million Americans, that would be over $1 trillion annually, which is obviously unsustainable and would bankrupt if that was the route that we started going.
Here's the thing. I think the real draw to these medications, I mean, how many times has somebody come to you and said, just put me on it for a couple months. I needed to get started, right? I think that people are so desperate because it's so hard in our modern food environment to do this alone, right? And to do this sort of without help and without a radical change, right? You can't just keep trying to portion control the dietary guidelines and expecting different results. A big draw that I think to these medications is, one, they kind of work. We have to acknowledge that.
For sure.
And I think people are just disenfranchised. And where would they turn to for help? Right? They turn to doctors for help. Their doctors have 7 minutes. What are they going to do? Can they really inspire change in 7 minutes?
So this is good timing. Someone just showed me this past week a message that they got from their doc when their A1C went from 6.4% to 7.1%. The message was, hey, your A1C has increased. I think you could continue the lifestyle changes you are working on, or we could add metformin. The lifestyle changes have potential to improve your A1C as well. Let me know. And that was the advice. It was continue the lifestyle changes you're on, which we saw just increase their A1C from 6.4 to 7.1, or add a medication. There was no concrete advice on actually how am I going to help this person in front of me. And the plan was just to follow up in 3 months and repeat A1C again at that point and make the decision about medication versus ongoing lifestyle changes.
I mean, I think people are out there, right? So like, look at the Super Bowl as an example. I was watching the Super Bowl and there was this amazing ad. It was like, the system's against you, calories in, calories out doesn't work. Eat less, move more doesn't work. We're being poisoned. We're being, the chronic disease epidemic is out of control, right? And I am like cheering on in my mind as I'm seeing this. I'm like, oh my God, this could be a Toward Health ad. Like, this is exactly all the things you think. And then it was like, actually, we want to give you, off-label or compounded GLP for $200 a month. Here you go. And I thought to myself, like, this is the world we've come to, where we're so bad at helping one another with chronic disease, that we are at a point where people rejoice, just like spending $3,000 a year on an injection drug to help them lose weight. Like it kind of made me sad, but it kind of made me excited, because then you showed me all the data that we have coming out, and all the, 43 pounds and 15.5% weight loss, and 16% in the people that didn't drop out. That's even better than some of these drugs.
Yeah, 100%. And I know I think you and I, we have used these drugs. So it's not saying that we never use the GLP-1 medications. In this study, we started 2 different patients on these medications. One who, despite making a really great effort and was succeeding following a low carb ketogenic diet, was still having really invasive food thoughts. And the medication has done really well helping her. And then another patient with diabetes who had amputations already coming into the study. And so, I think there's a potential time and a place for these medicines, but the problem is exactly kind of like you were saying, is they're so overused. And then I think we can talk about some of the potential downsides to these medications that are really, I don't think, discussed enough, or had a good informed consent discussion with patients when these medications are started.
I think besides the issue, yeah, and you're absolutely right. Like, this is not an all or nothing. Like, we are a medical clinic. We stopped 96 medications. We started 8, right, in this data set here that we're super proud about. 43 pounds off, A1C down, food addiction scores down, and people kept losing weight, even while stopping these meds. But you're right, nothing is all or none, right? And one of the things that I say to my patients all the time, and I know we've talked about this, is, it's like antibiotics. We don't blame an antibiotic. We blame the docs who are over-prescribing antibiotics. Now, if you have a little sniffle, taking an antibiotic is inappropriate. You may get diarrhea, you could get arrhythmia, allergic reactions, any of those things can happen. But if you're, septic, really sick, high fevers, low blood pressure, an antibiotic is great, right? So I think doctors have just lost that. And one of the things I was so proud about to see you and our whole team do is just judiciously and appropriately use medications, right? They're not something to be relied upon. They're something to be planned out, discussed with patients, and eventually stopped if and when possible. And the results of this is great. 96, you know how happy these patients are coming off the meds? They're like, I don't have to take any more meds. Like, really? Yeah, you're 40 years old and you're healthy now. Like, you don't have to take any meds. It's like, it's such a great sort of liberating thing. I've never met somebody who's like, give me more medications.
Yeah, I had one of the patients had been told their diabetes was chronic and progressive. We're going to be on their diabetes medicines for life. And within, I think it was just 1.5, 2 months, we had stopped 5 medications in this one person. And they just couldn't believe that they were off their medications, and their numbers were looking excellent on their glucose monitor. And after they had been told for years that they were stuck with this.
So you're the data guru. You're the sort of metabolic care lead in our practice. So, you're much closer to the data than I am. And I know we've presented a couple posters, but what are the other, besides the weight loss data, which was impressive in the study, and I think also the fact that people kept losing weight at 1 year, I thought that was pretty impressive.
Over 75%, yeah.
Yeah, but is there any other data that you were like, this is kind of cool? It's okay if you give people a behind the scenes, what do you think is like the coolest thing that you've seen so far?
Before we move on to that, because there are definitely a couple other things in this study. What I haven't mentioned yet is that we did stop 4 GLP-1 medications, and those people maintained their weight loss. Well, actually, some people continued to lose weight, and then 2 maintained their weight or did not regain more than 5%. So it was less than 5. which is not what you see in the large trials with GLP-1 medicines. So in the large trials, when people stop their GLP-1 medications, you see a very rapid weight regain. And so we did not see that, which is awesome. And I think it talks to the fact that these people had made a huge lifestyle change while they were taking these medications, and they were able to continue those lifestyle changes. And the other thing I want to point out too is, although these medications, we acknowledge they can be very effective, in the STEP 5 trial, 25, which was a trial in people who had obesity without diabetes, 25% of people had a less than 5% reduction in their weight. And so in our study, 92% of people had a greater than 5% weight loss. So those medicines are not going to work for everybody. No intervention, whether dietary or other, will work for everybody. But it's just 25% is a pretty significant number. And then 80% had GI side effects, whereas with the lifestyle changes, most of the side effects, you may have a few weeks initially, 1 or 2 weeks potentially, as your body's getting used to not having those carbohydrates around. But then after that, people are feeling better. They're not dealing with side effects that are creating issues most of the time.
I got to be honest, I think you cannot discount the side effects enough. A lot of people stop these medications due to the nausea or vomiting or the diarrhea. It's very difficult, and oftentimes you may need if you want to keep taking the medication, and they're taking a nausea medication to deal with the nausea from the GLP-1 drugs. So, they are certainly, I'd say, one of the better drugs we've seen in our lifetime in terms of the data we have for them, but they're like anything, they have limitations.
Yeah. And on the cost front in this paper, so the total amount of money on an annual basis that was saved from stopping 96 medications was $111,000. So just compare that again to the $13,000 of added money if you start a GLP medication for that year. And so if you kind of look at the net gain, basically that's over $83,000, which comes very close to $1,700 per person from medication deprescription alone. And that's not thinking about, one, the recurrent cost if you continue that out, but then the other long-term medical conditions that you are very likely preventing by reversing diabetes, by improving weight, and preventing all the other diseases that come along with those from having them for years and years.
Yeah, I mean, it's just any other key points from the study that you think are important?
Let's see. Those were the big ones I wanted to highlight. Just on the talk about the informed consent with the GLP-1 medications, I think something that needs to be emphasized with folks is that in some of the trials, the SUSTAIN trial, 30 to 40% of the weight loss that came from the GLP medications was from lean body mass or muscle. And that could in part explain, when stopping these medications, why there's a rapid weight regain. So I think emphasizing the importance of resistance training, and if you are going to be taking these medications, because we've seen, and I think some of our patients, they are actually getting stronger while they're losing weight on these medications and going to the gym regularly.
Yeah, 100%. I think the docs need to step it up a little bit. 7-minute visits and an injection are not appropriate.
Yeah.
100%. Any back to that question that I asked you, any behind the scenes sort of numbers that these are obviously not published and not peer reviewed, but anything you find interesting, crunching the numbers behind the scenes?
One thing I'm kind of looking forward to right now that we're in the works is looking at food addiction symptoms and binge eating symptoms. And we're seeing significant improvements in individuals in both of those areas. And so I'm excited to maybe in the next couple months have some data out there on that.
That'd be awesome. That'd be awesome. Can't wait. I'm super excited about that. Anything else you want to talk about?
Just that we are, I think, in a really exciting time now with seems to be more of a movement now about making America healthy. And I think hopefully with our data now out there, I know Verta's got data showing that lifestyle is a viable and very effective way to do it. You just need the correct support, the correct advice to actually make it sustainable and to make the results that we're looking for. So I'm hoping this will get out there, get to more people, maybe to some more employers that are looking to help their employees get healthier. And maybe we can start helping more companies improve their patients' metabolic health, their employees.
Yeah, I think the biggest thing is we put the blueprint out there. Real-time support, text messaging and telemedicine, online interactions are sufficient, wellness coaches and doctors are needed. Get an app, get some sort of asynchronous education, a community, real-time biofeedback, get the CGM, smart scales, blood pressure cuffs, Fitbits, Whoops, and get diets that support keto and intermittent fasting. And your clinic can also get these amazing results.
Yeah, I think 142 million people right now we said qualify for the GLP medications. And so we're going to need a lot of doctors interested in metabolic health, a lot of health coaches, NPs, PAs, everybody really to get excited about this. And like you said, try to promote and implement an intensive intervention like this to help people.
Yeah, and to echo that, we're here giving our resources away. We are licensing the app for next to free to any doc or health system. We have 12, I think, clinics and health systems that are using our app. And absolutely, if you're a self-funded company out there listening to this and saying, gosh, I want to get our costs down, I want to get our employees healthier, I want to embrace the metabolic health movement that we're seeing right now, this renewed energy to sort of tackle chronic disease, the executive order we saw signed, reach out to us, and we can help guide you. So, well, Laura, I'll give you the parting last words. So go ahead.
Just thank you so much for letting me be a part of this. I really do feel honored, and I love working with you, and I'm excited for what the future holds because I think we're going to hopefully help a lot more people.
Amen. Can't wait.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.